Orthopedic Center. He was also the
Kasi
chairman of the
15 minutes na siya
PSES External Affairs Committee for 2022-2023, and also my vice training officer in Our Lady of Lourdes Hospital. And he will be discussing about hernia, small intestines, and appendix. So, Dr. Ron C. Corcoro, take it away.
Hi, good afternoon. Ano ba? Good morning, guys. I'll just play a video of the lecture kasi mas mabilis ata pagka yung video yung malang yung tinig ko. Mark, can I share now?
Go ahead, go ahead.
Thank you. Good day. We will be talking about hernia, small bowel, and appendix in this lecture.
Full screen.
Hernia is the protrusion of an organ through the abdominal wall. There are several types. We have the more common inguinal hernia, the femoral, the umbilical, and the ventral hernias. For this lecture, we will be discussing more of the inguinal hernia and its management. The inguinal region is surgically important since it is the site of chronic hernia. The weakness in this area is brought about by the descent of the testes from the intra-abdominal space to the scrotum during the third trimester. This descent is preceded by the gubernaculum and a diverticulum of the peritoneum, which protrudes through the inguinal canal and becomes the processus vaginalis. At 36 to 40 weeks AOG, the processus vaginalis and the peritoneal opening closes at the internal inguinal ring. Failure of this closure results in a patent processus vaginalis. Premature babies would have higher incidences of hernias because of this. Other factors for the development of hernia will include the COPD, abdominal muscle weakness, straining from constipation, and prostatism. Low birth weight, family history, defective collagen synthesis, and cigarette smoking are also factors. Indirect hernia is the most common type of groin hernia, while the femoral hernia will be seen more commonly in females. The inguinal canal is a 4 to 6 centimeter cone-shaped structure where the spermatic cord or the round ligament passes through the canal ring. This canal is bounded anteriorly by the external oblique aponeurosis, posteriorly by the transverse caelus fascia, superiorly by the internal oblique, and inferiorly by the inguinal ligament. The inguinal ligament is formed by the inferior border of the external oblique aponeurosis, which will form the inferior wall or the floor of the inguinal canal. The inguinal canal starts at the deep inguinal ring and ends in the superficial inguinal ring. In males, this area will contain cremasteric muscle, testicular vessels, vas deferens, iliohypogastric nerve, the genital branch of the genitofemoral nerve, and the pentagenital plexus. In females, the round ligament passes through to attach to the labia. An important difference between an adult and pediatric case is that the inguinal canal is more diagonal in adults, whereas in pediatrics, the two rings are more parallel to each other. The Hesselbach's triangle is bordered by the rectus muscle medially, inferior epigastric vessel superiorly, and the inguinal ligament inferiorly. This area contains a depression referred to as the medial inguinal fossa, through which the direct inguinal hernia protrudes through the abdomen. The location of the inguinal hernia will depend on its location through the inferior epigastric vessels. Remember, medial to the epigastric vessel is a direct hernia, and the indirect hernia will be lateral to the inferior epigastric vessel. Again, important structures in your inguinal anatomy for your hernia surgery would be the superficial inguinal ring, which is the V-shaped opening in the aponeurosis of the external oblique, the deep inguinal ring, which is the opening in the transversalis fascia. The structures lead to the posterior wall, which are the inferior epigastric artery and vein, the Hasselbalch's triangle, which will dictate to you the location of your hernias. Again, medial to the inferior epigastric artery will be your direct hernia. Lateral to the epigastric artery will be your indirect hernia. Differences between the two types of inguinal hernia are: one, your indirect inguinal hernia is often congenital. Two, your indirect inguinal hernia will protrude through the inguinal canal, whereas the direct inguinal hernia will protrude through the posterior wall. During your physical examination, hernial content is appreciated pushing down the tip of your examining finger for your indirect inguinal hernia, while for your direct inguinal hernia, the hernial contents will be appreciated pushing against the pulp of your examining finger. Repair for your indirect inguinal hernia is done by closure of the inguinal ring while reinforcing the posterior wall. For your direct inguinal hernia, repair is done by reinforcing the posterior wall. There are different classification systems for hernia. The Nius classification is the more frequently used because it is more detailed. However, other classification systems like the Gilbert and the EHS classification are also often used to describe your hernia. The principle of a good hernia repair is that it should allow closure of the peritoneal sac and reduction of the hernial contents into the abdominal cavity, then reinforcing the abdominal defect in a tension-free manner. Most contemporary hernia surgeries employ a tension-free repair. Note that the most common cause of recurrence is because of too much tension in the area. There are several options for hernia repair. Herniotomy is reserved for the pediatric age group. Your herniorrhaphy is the tissue repair of the abdominal wall defect, while your hernioplasty uses prosthetic meshes to reinforce the abdominal wall weakness. A common question you'll hear is, why is mesh generally not used in the management of pediatric hernia? Answer is because 1. Congenital hernias are caused by a patent processus vaginalis, not a weakened abdominal wall. And 2. Mesh generally shrinks to 50% of its original size. As the child grows older, the inguinal canal lengthens and eventually will outgrow the mesh. Herniorrhaphy is the open, non-prosthetic repair of a hernial defect. Different types include your Marcy, your Bassini, your Scholdice, your McVeigh, and your Desarda. Bassini repair employs high ligation of the hernial sac and the reinforcement of the inguinal floor by approximating the conjoint tendon to the upper leaf of the transversalis fascia. Suturing is done by interrupted fascia. Your Scholdice repair has the lowest incidence of recurrence among the tissue repairs. It employs placement of 4 lines of sutures over several tissue layers, effectively distributing the tension along a reinforced floor. The first suture line is started at the pubic tubercle using a 3-0 continuous proline, and the white line is approximated to the free edge of the inferior transversalis fascial flap.
For the second suture line, at the internal ring, the suture is tied and then continued medially by approximating the free edge of the superior flap to the shelving edge of the inguinal ligament. When the pubic tubercle is reached, the suture is tied and divided. The third suture line started at the level of the internal ring, where the conjoint tendon is approximated to the inguinal ligament and tied when the pubic tubercle is reached. Using the same suture, the fourth suture line attaches these same structures to one another and is tied at the level of the internal ring. The McVeigh repair is almost the same as the Bassini repair, but relaxing incisions are placed at the anterior rectus sheath to reduce tension. This employs opening up the transversalis fascia, and then the Cooper's ligament is sutured to the aponeurosis of the transversus abdominis. This repair covers all three groin defects: the indirect, the direct, and the femoral. Herniaplasty employs the placement of prosthetic mesh to cover the hernia defect. This is done either through open or laparoscopic techniques. Mesh placement can either be on-lay or pre-peritoneal for the open techniques, while laparoscopic repairs uses the pre-peritoneal space. Liechtenstein technique employs placement of a mesh on top of the attenuated inguinal floor. The hernial sac is ligated at the level of the pre-peritoneal fat. Then a mesh is placed on the transversalis fascia. The mesh is anchored initially at the pubic tubercle, then sutured to the inguinal ligament and the conjoint tendon. A common complication of this technique is osteitis pubis, where the suture is placed too deep into the symphysis pubis. There are two types of laparoscopic hernia repair. They are your transabdominal preperitoneal procedure and your total extraperitoneal procedure. The difference between the two is that the TAP, or your transabdominal preperitoneal procedure, goes through the abdomen and accesses the preperitoneal space through the posterior approach, while your total extraperitoneal procedure will not go into the peritoneal cavity. Your TEP involves preperitoneal dissection and placement of mesh without entering the abdominal cavity. This is done by using a balloon dilator to dissect the preperitoneal space to create a space of Bogos, where a proline mesh is placed to cover the defect. A common pitfall of this technique is the failure to identify the inferior epigastric vessels, which may lead to difficult bleeding in the area. Your TAPP requires laparoscopic access into the peritoneal cavity and placement of the mesh into the preperitoneal space after reducing the hernial sac. In this technique, one must be aware of the triangles of doom and the triangles of pain. The triangle of doom is bordered medially by the vas deferens and laterally by the vessels of the spermatic cord. The contents of the space include the external iliac vessels, deep circumflex iliac vein, your femoral nerve, and gentle branch of the gentle femoral nerve. Placement of staples and tackers in the area can result in a severe, difficult to control bleeding. The triangle of pain is a region bordered by the iliopubic tract and the gonadal vessels. This encompasses the lateral femoral cutaneous, femoral branch of the genitofemoral, and the femoral nerves. Placement of staples or dissection in the area will result in severe post-op pain. There are several important variants of your groin hernias. First, your Amiens hernia, where the appendix is within the sac of the hernia. Your Litter's hernia contains the Meckel's diverticulum. For your pantaloon hernia, both the direct and indirect will be seen. A sliding hernia is seen if a portion of the hernial sac is formed by the wall of the retroperitoneal organ. Richter's hernia is a hernia where a portion of the bowel is herniated and strangulated, but no obstruction is seen in your patient.
Special types of groin hernias are important to know since management will differ. A pantaloon hernia is a combined direct and indirect hernia. A Richter's hernia is the herniation of the anti-mesenteric border of a bowel. Your Amiens contains the appendix, while your Litters contains a Meckel's diverticulum. A sliding hernia is seen when part of the wall of the bladder or a bowel forms part of the hernial sac.
The appendix is a lymphoid organ that measures around 2 to 20 centimeters. The blood supply is from the ileocecal artery. Early in life, this produces IgA. Appendicitis is caused by the blockage of the appendiceal lumen by fecalith or lymphoid tissue inflammation. Proximal obstruction results in a closed loop obstruction. Continued secretion of the intraluminal fluid causes distension and leads to the stimulation of visceral afferent stretch fibers, causing the dull epigastric mid-abdomen pain initially seen in patients. Increased distension from the continued mucosal secretion and rapid multiplication of resident bacteria causes reflex nausea and vomiting. Once venous pressure is exceeded, engorgement and vascular congestion happens. Once the serosa becomes involved, the parietal peritoneum becomes irritated, which will lead to the shift in the pain to the right lower quadrant area. As pressure increases, arterial pressure is exceeded, leading to distal infarction. Progression of ear infarction leads to necrosis and eventual perforation. Diagnosis of appendicitis is usually by history and physical examination. However, imaging modalities may help in equivocal cases. Your CT scan may be requested in older patients who may have unusual presentations or other possible pathologies. Ultrasound is the standard imaging for young children and pregnant women. Surgery is the primary treatment for appendicitis. This can be done through a standard Grocki-Davis incision or laparoscopically. A single dose of second-generation cephalosporin can be given 1 hour preoperatively for non-perforative cases. Antibiotic of choice for your uncomplicated cases would be your cefoxitin. For perforated appendicitis, ertapenem is given. Antibiotic coverage for ruptured appendicitis should always include anaerobic coverage, like your metronidazole. Some appendicitis cases may benefit from non-operative management. For this approach, there should be no appendiculate. Size should be less than 1 centimeter in diameter, and there should be no peritonitis, perforation, or phlegmon. According to the CODA trial, 50% of patients who will undergo non-operative management will eventually need to have surgery within the next 4 years. Antibiotic treatment alone is not suggested for children, for adults, or for patients who are pregnant, or for those patients with sepsis or who are immune compromised.
Pati kayang slides yun. Ano mo, nasulok pa ng...
Patients who are qualified for conservative management should be admitted and monitored for any progression of their symptoms. IV ceftriaxone for up to 3 days will be given and then shifted to oral antibiotics for 5 to 10 days.
First 2019.
Appendiceal tumors are rare tumors often diagnosed post-operatively by histopathy. There are instances where CT scan can detect this condition, often showing dilated fluid-filled appendix.
Presentation and compound. Ayaw lang sa operahan na.
Really do. Inadjust na to sila ng ayaw lang sa in-off lang sa
Dok, that time mo-
Appendiceal tumors can be divided into epithelial and non-epithelial. The epithelial tumors are further divided into mucinous, which includes your low-grade mucinous appendiceal neoplasms, and the high-grade appendiceal neoplasms, which includes your mucinous adenocarcinoma of the appendix. The non-mucinous tumors are the colonic type adenocarcinoma of the appendix. Non-epithelial tumors will include your neuroendocrine tumors, your lymphomas, and your sarcomas.
uuwi ka ay.
Napagod siya, ano do? CT scan.
Appendicitis.
There are currently no known
Nasa
factors
sila
for
po,
developing
wala kay Inglo,
this type of
antibiotics, pagbalik sa-
mucinous epithelial tumors may present as fluid-filled dilated appendix during appendectomy or preoperatively by CT scan. Rupture of the mucinous contents into the peritoneum causes pseudomyxoma
Aware mo din
peritoneae.
daan na appendicitis.
Your low-grade mucinous appendiceal neoplasms are slow-growing, well-differentiated lesions, which often leads to cystic dilatation of the appendix. These lesions include your appendiceal neoplasms, cystadenomas, borderline tumors, and mucinous tumors of undetermined behavior.
Same with head and neck. Kay, may ko head and neck, thyroid rin mo i-discuss na pa ba kay oral salivary o ano.
Management of LAMN is appendectomy with clear margins. If there is doubt about margins or margins are not likely achieved by appendectomy alone, do a cystectomy. Surgery can be done either by open or laparoscopic procedures. Care should be done to prevent spillage of mucinous contents into the peritoneum to avoid pseudomyxoma peritoneae. If ruptured during surgery, stage and collect specimen for biopsy and cellular examination. Cellular mucin is more likely to develop pseudomyxoma peritoneae. A cytoreductive surgery is recommended to include all prostheses, and chemotherapy with mitomycin C is initiated.
Wala pa na.
I-admit pa na. Karon, I'm not sure dapat admit na morning. Better mo good morning kay hasul mang ay.
For your high-grade appendicial mucinous neoplasms, lymph node spread may be seen in 17% of cases. A right hemicolectomy to include regional lymph nodes would be necessary. If diagnosed preoperatively, T4, perforated, or with positive margins, you may consider a prophylactic HIPEC at the time of right hemicolectomy. Perforated tumor, debulking surgery in HIPEC is recommended.
7.
To note, mucinous adenocarcinoma with signet cell ring has the poorest prognosis among the types of high-grade tumors of the appendix.
If madayon mang yun ni 1P.
Unsa ka to kay Dr. Leon?
Katong bakat itong ano iba.
In patients with high-grade disease, nodal positivity or mucinous
first
adenocarcinoma,
pa lang yun.
staged with CT of the chest, abdomen, and pelvis, and if distant metastasis is seen, systemic chemo using 5-FU, leucovorin, and capecitabine will be indicated. Note that recurrence is very high.
Wala pa ninyo ma-clearance o CT clearance yun.
Colonic type adenocarcinoma is treated as you would a colon CA. If detected preoperatively, request for chest, abdomen, and pelvic CT, CEA, and colonoscopy. If identified postoperatively, stage and do colonoscopy. Management is always stage dependent.
Saved.
Saved by the bell.
Saved by the gastric. Gatawan na lagi kasi sige mo.
Management of colonic type
yung
adenocarcinoma
gastric.
is dependent on the T-staging and the end staging. So, T1 with unfavorable characteristics will require a right hemicolectomy. For T2 lesions, stage the tumor and do colonoscopy for possible metastasis. Stage 2 with high-risk features will need a hemicolectomy plus chemotherapy. For stage 3, which are node positive, hemicolectomy and chemotherapy is also warranted. If metastasis to the peritoneum is seen, consider cytoreductive surgery plus intraperitoneal chemotherapy. If with systemic disease, recommendation is always to do chemotherapy. Neuroendocrine tumors are from enterochromaffin-like cells and are often secreting serotonin. These lesions are often found post-operatively. Most common signs and symptoms would include skin flushing, facial skin lesions, diarrhea, difficulty breathing, and rapid heartbeat. Often, these cases present as abdominal pain, diarrhea, and appendicitis. Management will depend on the size, grade, stage, and high-risk features. For grade 1 lesions not located at the base, appendectomy should be sufficient. For grade 2 or grade 3, located at the base of the tumor, a right hemicolectomy is recommended. For tumors 1 to 2 centimeters that do not involve the base, appendectomy is adequate. Again, if the lesion is less than 1 centimeter, appendectomy should be sufficient. If lesion is 1 to 2 centimeters, located at the tip or the mid-appendix, appendectomy should be enough. But if the lesion is located at the base or the mesoappendix, then hemicolectomy is recommended. For lesions more than 2 centimeters, regardless of location, a hemicolectomy is warranted. Lymphoma is suspected in patients with more than 2.5 centimeter diameter appendix on CT scan. If confined to the appendix, appendectomy should be sufficient. If lesions extend to the cecum or mesentery, then do a right hemicolectomy. No chemotherapy will be recommended for patients with lymphoma confined to the appendix. Small bowel obstruction presents with gas and fluid-filled bowels proximal to the site of obstruction. Initially, intestinal activity increases in an effort to overcome obstruction. This leads to colicky pain and diarrhea. As this tension increases, intraluminal and intramural pressure increases. The motility will eventually decrease. The increase in intramural pressure leads to impairment of the microvascular perfusion, which can lead to ischemia and necrosis. An SFA should always be requested. You look for the dilated loops of bowels. For your small intestines, it should be more than 3 centimeters. Your colon should be more than 4 to 5 centimeters. The cecum should be around 8 to 10 centimeters. A stepladder configuration is usually seen. Paucity of the air in the colon is also noted. A CT scan can be requested to evaluate for the abdomen. Closed loop obstruction is suggested by the presence of a U-shaped or C-shaped dilated bowel loop associated with a radial distribution of mesenteric vessels converging toward a torsion point. Your strangulation is suggested by the thickening of a bowel wall, pneumatosis intestinalis, portal venous gas, mesenteric haziness, and poor uptake of intravenous contrast into the wall of the affected bowel. Enteroclysis is requested to evaluate for partial SBO. Water-soluble contrast is instilled, which causes a shift of fluid into the lumen, which increases the pressure gradient across the site of obstruction. This may help hasten the resolution of a partial SBO. Enteroclysis can be done by giving 200 to 250 ml of barum, followed by 1 to 2 liters of a solution of methyl cellulose in water instilled into the proximal jejunum via a long mesoenteric catheter. The double contrast technique used in enteroclysis permits a better assessment of mucosal surface and detection of relatively small lesions. Conservative management may be recommended for partial gut obstruction and obstruction from early post-op adhesions. Also, adhesions due to Crohn's disease or carcinomatosis may benefit from conservative therapy. An NGT is placed to drain the air and the fluid, and meticulous fluid resuscitation is done as a conservative therapy. Crohn's disease is an inflammatory disease with histologic hallmark of focal transmural inflammation of the intestine. Any part of the alimentary tract may become involved, however, rectal sparing is often observed. The earliest lesion characteristic of Crohn's disease is aphthous ulcer. About 70% of cases will have granuloma, thickened wall with violaceous appearance of the serosa, and skip areas of normal bowels. Cobblestone appearance is a characteristic feature of Crohn's disease. An EGD and colonoscopy with biopsy is recommended. CT scan is also requested to detect intra-abdominal disorders like fistula formation. Small bowel series may show thumb printing and string signs. There are no known cures for Crohn's disease. The goal is to palliate the symptoms through nutritional support and initiation of mesalamine, sulfasalazine, steroids, antimetabolites, and anti-TNF, which will promote closure of enterocutaneous fistula. Surgery is reserved for acute colitis, toxic megacolon, and development of obstruction, perforation, hemorrhage, or malignancy risk, and strictures. Most patients whose disease is resected eventually develop recurrence. Endoscopically, 70% recur within 1 year of bowel resection and 85% by 3 years. Clinically, return of symptoms confirmed as being due to Crohn's disease affects 60% of patients by 5 years and 94% by 15 years after intestinal resection.
Yeah, but ikaw yellow.
Key differences between ulcerative colitis and Crohn's disease is that 1. Crohn's disease is full thickness, discontinuous and spares the rectum, is P-ANCA negative, and ASCA positive.
Sabol mo yung uban ng gym mo ay
For your intestinal fistulas, phases of care include stabilization and recognition, drainage of obvious abscess, nutritional assessment and beginning of nutritional supplementation, and spontaneous cure.
I cannot read anything that's black. So, kailangan ko pa ng colorful to be able to read.
Factors that inhibit spontaneous closure include presence of foreign body, radiation and uveitis, infection or inflammation, epithelialization, neoplasms, distal obstruction, or short tracts and high output fistulas.
Kasi preset mo si malit sa po.
It would be prudent to wait for 2 to 3 months before doing any surgical intervention. About 90% of cases will resolve within 5 weeks. Intervention after 8 weeks lowers the chances of significant morbidity and can result in better outcomes.
Nag-stasis, I curse you, sayang ka siya.
Short bowel syndrome is defined as the presence of less than 200 centimeters small bowel in adults. Because of the shorter bowel, absorptive capacity is decreased and can result in diarrhea, dehydration, and malnutrition. Lifetime dependence in TPN is seen in patients without functional colon in less than 100 centimeters small bowel and in patients with functional colon but has less than 60 centimeter residual small intestine.
Ako dapat ko ballpen sa ano na nga, dapat tayo ko colored ballpen sa dala.
The following factors determine the severity of obstruction. 1 is the residual small bowel length. 2. An intact colon. 3. An intact ileocecal valve. 4. Healthy union bowel. Resection of jejunum is better tolerated than resection of ileum, as the capacity for bile salt and vitamin B12 absorption is specific to the ileum.
Man, yun, di na siya magsulat. Kuan na naiya ka ng iPad ra pag yun. Kaya ba
Ma-amaze ko ano
Medical management would include TPN, PIs, histamine blockers, and octreotide.
Ano oil right? Mura good si Tweety dapog. Highlight ra sa kigwan.
There are several surgical techniques that can be offered to patients. The goal of surgery is to increase the nutrient and fluid absorption by slowing intestinal transit and increasing intestinal length. Operations designed to slow intestinal transit include segmental reversal of small bowel, interposition of segment of colon between segments of small bowel, construction of small intestinal valves, and electrical pacing of the small intestine. Intestinal lengthening would include your longitudinal intestinal lengthening and tailoring, and serial transverse enteroplastic procedures.
Tanawa, na ko screen record.
Ako na ko screen record, pero usually
Pero sa phone no, hindi ligid siya.
Nakasulay ko sa laptop. Not unless ang imong gamit pang record kay na quick time.
Mayan eh. Ay, pas man.
Okay na look.
Ala, basig mo na yung iyahang ano.
Dr. Torres, that's your last slide.
Mo na iya.
Wala
Kasi no,
last.
kay ihar man gagi.
Hindi na kasi masyadong makita yung ano.
Ah, ang cute yan ang mama. Is that
The
your
size of
mom?
the text.
Key points. Oh, nag-ano siya.
COP pagod ni Tuesday.
Ito na po, ano? Clinical key.
Ano siya?
Esther, that's the last slide. Actually,
Kinabahan ako eh. Kinabahan ako, biglang ano yung screen mo, baka mamaya kung ano mag-flash eh.
But we can, we can give the,
Stop na rin ako
questions
record
na
ka.
lang. Kasi usually,
Tapos?